Hi, good morning, good afternoon, and good evening to everyone. We have quite an attendee across the U.S. Joining us today. I'm Clint Owen, VP of Enterprise Sales for HealthRecon Connect, based out of the Dallas-Fort Worth area. Today, we're going to be having a webinar discussion about what's paying now, an infectious disease update, and it will be delivered by one of our subject matter expertise within our system here. But before we get started into that and introduce William, I want to go through a couple reminders. If you'd like to ask questions, you may do so by sharing your questions via the chat box or by raising your hand, and I'll be monitoring that myself, upon which one of our team members will enable your audio to ask that question. Following the conclusion of the webinar, please take a few minutes of your time to fill out a short survey and let us know what you liked about this webinar and how we can improve what other topics you would be interested in for future webinars. As a reminder, the recording of this webinar will be published on our social media pages in the next 2 to 3 weeks. Please do keep an eye out for that post and do share the link with your colleagues who couldn't make it today and with those who may find the content covered during this webinar useful. With that, let me do a quick review of the agenda and I'll introduce William and we'll get started. So general kind of agenda topics today. We'll be going over COVID-19 and monkeypox coding and billing, if you will, diagnostic testing and screening, variant testing, PCR and antigen, reimbursements, HRSA and CARES Act, and no doubt much more that William has in store for us. So with that, let me do a quick introduction of William. William Baus has been in the healthcare industry for 15 years, dealing within healthcare revenue cycle management. His last decade has been entirely focused on laboratory revenue cycle management and building onshore, offshore, and hybrid teams to satisfy the needs of his clients. William has worked inside laboratories as the internal revenue cycle director with preview over every step in the revenue cycle process, as well as managing RCM vendors. William is tirelessly focused on compliantly maximizing the revenues of laboratories, whether that is through the adoption of technology, application of deep state knowledge of payer and national coding policies, or providing access to relationships that can change the bottom line for labs and our clients. With that, let me turn it over to William. Take it away, William.
Hi, everybody. Thank you for joining today. Just to confirm, Clint, we can see the screen. What's reimbursable now? PCR.
Yes, sir. Yes,
okay,
sir.
Great. Yeah, I gave a little update to the name. I thought it sounded a little snazzier. We're going to go on an odyssey on PCR, what we're getting paid for now. So thank you for joining us. And here's our agenda for today. We're going to run through infectious syndromic panels, Moldex versus non-Moldex, and Z codes and TAs and an LCD and a billing and coding article. We're going to get that stuff out of the way because it's going to apply to everything else that we talk about. I'm going to have to cut PGX off today, I think, because I had to add a few new things, some new updates today that just figured out very recently. So I wanted to communicate that. I'm going to be able to look at it from a commercial perspective on all of the panels, whether it's Moldex or non-Moldex, what's going on in Novitas and First Coast and NGS. So that'll cover us for everybody. And then the commercials. Then we're going to run through all the panels. Then we're going to have what's going on with COVID and a few other updates I wanted to give you guys. But as always, we may be discussing things that might get into a legal realm. We're not offering legal advice. Even the codes that we see on the screen, I wouldn't just run off with these codes and change your panels. They should definitely be reviewed in their totality with what your business model is and whether you're referencing or not, for example, and whether you're a pathology lab or not, or whether you're an anatomic pathology physician office or not. All of these things can have an impact on what coding should be. So don't just utilize this information here and then not have it reviewed by, certified coder. And if there's something that brings up a legal situation, talk to a lawyer. All right, so the first thing that we need to kind of understand that we're talking about is what's a Moldex MAC versus a non-Moldex MAC. And so Moldex, what is that? What is that program? What is a MAC? So a MAC is a Medicare Administrative Contractor. As you can see on the screen in front of you, there are differently highlighted geographic regions encompassing as little as maybe 2 states to as many as 8 states, right? So Noridian actually has 2 jurisdictions, and that can be confusing if you actually look up an LCD. You'll see them having the same LCD twice. And the reason they're doing it twice is because they do an LCD, a local coverage determination for each jurisdiction. Now, certain jurisdictions utilize the MolDX program, and the MolDX program is about Z codes, and we're going to talk about that in a quick minute as well. But for now, all I wanted to get everybody to understand is whatever state you're in is how your claims will be processed. So, for example, if you were in Houston and you received a sample from Ohio, it will be processed under the jurisdiction of Novitas if you're the billing lab. So wherever your lab resides, it doesn't matter where the sample is coming from or collected or what Medicare jurisdiction the patient lives in, which might be different than where the sample was collected. None of that is relevant as far as Medicare is concerned. And you process the sample under the rules, the jurisdiction of the MAC that you reside in. And in that case, if it was Houston, it would be Novitas. If you were in, say, South Carolina, it would be Palmetto. And then that would be different for you in a big way because that MAC utilizes the Moldex Z code program. So there are 4 MACs that do that. It's Palmetto, which is here. It is CGS, which is here. It's WPS, which is here and over here. And then Noridian, which is all of this pink and dark blue. The other 3 MACs do not use the Moldex program, and so that'll be here, Novitas, which is basically Texas and the contiguous states, plus Colorado, and then Pennsylvania and Delaware and Maryland and all those little guys right there. And then, of course, First Coast is down here with Florida and Virgin Islands and Puerto Rico. And then you've got NGS, which is basically New York and north all the way up to Maine, and also over here just to the west of the Great Lakes. Illinois and Minnesota and those guys. And so they don't use the Moldex program. So that's who we're talking about. And I'm going to be talking about both. I'm going to be talking about Moldex MACs versus non-Moldex MACs. All right. So then real quick primer on what is the Molecular Diagnostic Service Program. And I'm going to actually be bringing up something more interesting to look at here. So let's talk about that. So and what is the Moldex program utilizes the DEX Diagnostic Exchange Registry, which is a database that you go to and register your lab, and then you tell them all about your tests and you put that online. And then, another really kind of important thing is, well, who do I need to be worried about with a DEX Z code? And well, it's those 4 MACs we just talked about. So it's Palmetto, Noridian, WPS, and CGS. And Medicare Advantage programs, currently United Healthcare has stated that they're going to do that. So any Medicare Advantage UHC plan, you are potentially going to need to have a Z code for it. It is still under contention whether or not you're going to need it for a lab that's in a non-Moldex MAC. They're supposed to inform us if and when that happens. And there are also these 3 other payers. So you'll notice there's already a Blue Cross Blue Shield of North Carolina. So that kind of telegraphs that perhaps in the future, additional commercial payers may adopt the Moldex Z code program. It looks like United's definitely taking a look at it. And they already had a program in place, commercially speaking, when you were in network with them, where you went through a process very, very similar to getting a Z code. And since we just brought that up, I thought we should look at what that takes to do. So let me show you that real quick. So you say you need a Z code. Well, what is a Z code? Well, a Z code is not a payment code. A Z code is, in fact, a descriptor that was originally developed by the McKesson group back in 2011. And then was subsequently purchased by Palmetto as a company in its own right, which also happens to be a Medicare administrative contractor. So the thing to understand is the Moldex program is owned by Palmetto, but it is separate from the MACs. And so a MAC has to participate in the Moldex program, and we just reviewed who those were. This is a set of about 36 fields that when you log into the DEX Exchange program that you fill out, you put in your test ID and you tell them whether you're the performing lab or not. and what's the intended use, and your components and your analytes and the variants that you're looking at, and mutation types, and if you were FDA approved or not. That's what all this purple is. And then you start telling them about your test type and what diseases and disorders is it related to, and methodologies, and what medical specialties will be ordering it. All of this is kind of information that's not contained in the CPT code. And now that's what the Z code does, is it tells the payer additional information that the CPT code does not provide about what test it is you are running. And then the very big component, most important component of a Z code is what CPT code you get with that. And then there's some more advanced stuff that you put in to provide additional information. Some of it you'll see again when you perform a technical assessment. And when we talk about that, you're going to have to deal with, you'll need a Z code, and you'll need to be assigned an appropriate CPT code to use. You're going to ask for the CPT codes that you've been currently billing, but then they're going to tell you which CPT codes they're going to let you use. And this can go into an additional step where you need a technical assessment for your test, which we do need for the syndromic panels. A technical assessment looks a lot like the kind of information you would see when you were validating your LDT, your laboratory developed test. 1 second, I'm having a protected view problem to show you that. Unblock, apply, and here we go. There we go. And just to give you a brief understanding of what this is, it'll be a collection of 4 tabs that you go through. Your test information goes in here, and this is pretty basic. It's when you get into the analytical validity and the clinical validity section that you'll have perhaps some difficulty in collating the data that you did for your validation studies and getting it in the format that they want here. But it definitely can be done. And then you have your analytical validity and your clinical validity sample level data. And here is where, if you're not going to pass your technical assessment for a UTI, it is going to be related to the clinical utility section. This is probably the most important component in relationship to the medical necessity of the testing that you do. They need to know that there'll be a change in treatment with the patient that everybody agrees upon. And so effectively, the biggest complaint that they have about doing polymer chain reaction testing on anything basically besides respiratory pathogens and GI pathogens will be that the sensitivity for the testing is so great that there is this concept of a false positive narrative, and there's no standard of care associated with how is a physician supposed to deal with the potential that we've detected a pathogen that is not actually causing the infection. And so we're looking for literature on that. And in fact, to take us back to here, there are FAQs that are very good that tell you a lot of information about what they're going to approve and what they're not going to approve. This happens to be the FAQ on what is needed for a complete technical assessment submission. And so you can go and read all of this information on your own, but they tell you exactly the steps. There's even a checklist that walks you through all the steps you need to do, and they tell you what information you need, and you can even email them questions. I'd probably read this first though, because they do take a long time to respond sometimes. What's really important that I want everybody to understand, as of now, as of today, there is not one lab that has passed their technical assessment. It is related to the clinical validity section that I mentioned, and specifically it's related to the documentation that supports the false narrative, the false positive narrative related to the higher degree of specificity for detection of pathogens that PCR creates. So what they're telling you here is all of this documentation, all of this, and it's a growing list. I mean, it's gotten 3 times bigger than 2 weeks ago when I saw it. They're telling you don't send us these literature selections, because that's not going to help you pass your technical assessment for your UTI panel. And so look for something different. So that's a little tip for anybody that's doing this. You're not going to get it through with just that. All right. So Yeah, so we talked about Medicare Advantage plans. All right. So one big thing about the syndromic panels in the Moldex Max, all right? So it's only the Moldex Max that we need a Z code for, to be clear. There is somewhat of an out in that LCD and billing and coding article that basically stipulates that, well, if you don't have, you don't need a Z code if your test is FDA approved. So, but it's not as simple as that. So even if I was using, say, a biofile for an RPP, I would still need to, look at, am I using a diagnostic code with a CPT code that exists in the billing and coding article? Then I wouldn't need a Z code. But even if I was FDA approved and I wanted to use a different CPT code that isn't in the billing and coding article, or a diagnostic code that I'm going to put down isn't going to be one that appears in the article, you're going to need a Z code. And then that means they're going to give you a different CPT code called an 87999, for which you would have to do a gap fill. And very quickly, I'll try to show you what that looks like. Let me see, open that one there. Where'd it go? It's coming out. So a gap fill is what you would use if you can't use a CPT code that already exists. 87999 is a not otherwise classified CPT code, and those do not come with a fee schedule because they use it for lots of different things, so they can't really set a standard fee schedule. But with the combination of your Z code and an 87999, they know exactly what test it was you did, and therefore they can come up with a price. And the way that they do that is you fill out a form like this that runs through all of this type of information. We even put down the CPT codes we wanted to bill and what the normal price for that was, and then they come up with a price for that. And we can talk about that as it relates to the individual pathogen panels in a minute. Okay, so let's kill those and let's move on. So how does the LCD and billing and coding article work, and what testing is covered under the LCD? All right, so I'm going to show you the LCDs for syndromic molecular diagnostic tests. As they relate to the Moldex Max. And then we'll talk about the non-Moldex Max. Okay, so we're going to do that every time. All right, so the Moldex molecular syndromic panels for infectious disease and pathogen identification. So that means I'm going to have 4 of these. I'm going to have one for CGS. And I also have a billing and coding article tied in with every LCD, and the billing and coding article tells us very specific information on what CPT codes and what diagnostic codes we can use. Now, between these 4 MACs, the content is exactly the same. There are some semantics or some formatting issues that might vary between them, but in terms of the content, it's all the same. So I will eventually be just looking at one when we talk about certain things. Now, what I did notice is that the CGS Max, which is what we're looking at, and again, you'll see the names of the states and stuff every time you look at the contractor information. But if I look at CGS and Noridian, for example, and this will be Noridian, I will see everything will be the same as all Macs are, but what is different between CGS and Noridian, that's different between WPS and Palmetto, were the dates of implementation. And what I liked about CGS and Noridian was that they both put down very highly color-coded for you to see when their policy was exactly effective. So, and they went back and forth on it, right? I mean, at one point it was supposed to be 6.1, then it was 7.16, then it changed back to 6.2, and then it was 4.16 at one point. Well, now for CGS and for Noridian, it was actually effective as of 6.2. So prior to a data service of 6.2, you didn't need to worry about it if you were in those regions, right? So if you're over in California, it didn't happen for you until 6.2. Now, alternatively, for WPS and Palmetto, so let's say if you're in South Carolina, for example, what Whereas it might say it started on 416, you will see that there was a revision, that certain parts of the LCD weren't put together until basically 517. So you kind of have to worry about it like half a month earlier than the other half of the US, right? So that's really the only major differences in between it. And so that's really the key element of the difference between the LCDs between the Moldex Max. Now, a billing and coding article will tell you exactly very, very specific elements of information, such as what CPT codes require a certain combination of diagnostic codes. So for example, if I was going to do a targeted respiratory panel, I'm going to end up billing either an 8763136, an 87636, or an 87637. Or if I actually was using somebody's FDA approved who had gone off and gotten their own PLA code, a proprietary laboratory analysis code, well, then I would use a PLA code. You would know if you needed to use that code because your vendor that you bought your test from and set everything up would tell you that, right? 87801 doesn't really make a whole lot of sense. It's worth $70. These three codes here are all worth the same exact dollar amount and are all telling you the same thing. It's 3 to 5 viral targets, but this one is take your choice of what they are. This one tells you it's COVID A and B, and this one tells you it's COVID A, B, and RSV, right? So they're all worth the same dollar amount. That's what they want to pay you. They don't want you billing a whole bunch of other codes on top of it. And they're very clear about this. And so that is the point of a billing and coding article. And so basically what you would do is you would focus in on group 1 and you'd say, okay, I want to know what diagnostic codes I need to use. So you would just type in group 1, and I don't even know why they put a 59 modifier in there because you're not going to use it that much. But these 112 diagnostic codes are one of the diagnostic codes you would need to get paid for RPP. Now, we're going to get into that in more detail when we go over each pathogen panel, but that's effectively how a billing and coding article works. Now, what's more important is to understand some of the basic elements of the LCD and the billing and coding article, because it's going to come up again about 5 times as we go through every panel. So the first thing to understand is that the LCD is talking about testing that's greater than 1 pathogen. So, for example, anything that like monkeypox, for example, is a single pathogen test, or if you ran it as a single pathogen test, then this policy does not apply. The same for COVID testing as well. If you were doing COVID only testing, this doesn't apply. You don't need a Z code for it. So that's usually a little trick there people didn't quite pick up on. The other thing is that this test is related to nucleic acid amplification tests. So PCR tests of all types, right? All NATs of all types. There are other types of nucleic acid amplification besides PCR. So all of those would follow. What is not included in this test are mass spectrometry, and it's in here just to make sure everybody's on the same page with me. Let's see, next. Yeah, so they'll tell you right in the policy, this is not a coverage policy for NGS, mass spectrometry, or FISH. What they also didn't tell you, but they kind of thought everybody would be clued into, is since we're talking about nucleic acid amplification tests, well, then also an antibody test would not be a part of this, an antigen test would not be part of this, a culture would not be part of this. Those would be other types of tests that as far as cultures go, you may actually, and you do have in many Macs, an LCD governing how you handle the billing of those kinds of testing. Another thing that they say in here too is that this policy does not cover inpatient testing, which is right here. So now we've kind of got an idea of what this policy is covering. The next thing that we need to kind of talk about is understanding the relationship between the groups and what code group 8 is, which we will get to momentarily. So let's see, this is the LCD. Oh, I wanted to point out one other thing that has been confusing to people. The information I provided about being FDA approved or not is included here. It is repeated in a third document that's always associated with these other two, which is called a response to comments. And in that response to comments, they will indicate and many times that you need to have a Z code and you need to have a technical assessment to demonstrate compliance with this policy. And they're really very specific about it. And there's even some additional information that even if you did do an FDA approved test, but you only did, and you did anything more than one test, well, then you need a Z code for that as well. And we're going to talk about that in just a second. But it is here that people have been confused because they see the words here, coverage for expanded greater than 5 pathogen panel testing below. And they assume that this sentence here that I have highlighted means it's only relevant for greater than 5 pathogens. And that is not the case. As you can see, what we are looking at here is the general criteria. So all of these bullet points are related to the general criteria. Then there's general non-coverage criteria, which is very similar to what you would expect. And then you see under here, now we are starting to talk about limited coverage for expanded greater than 5 pathogen panel testing. So, and we will talk about that in quite some detail, but this bullet point here applies for the entire document. So I just wanted to make that clear because it does seem to be a lot of confusion about that. Now we're going to take a look at the billing and coding article, which is the one that's very specific for us. And I wanted you to read a few things in here. What's very important to understand that is if you're not using a CPT code, if no specific CPT code exists, they're talking about in the billing and coding article, not that it doesn't exist at all, although they're meaning that as well. But if you're not going to use a CPT code in this article, you're going to be given an 87999. And if you have an 87999, you're going to need to have a technical assessment and a Z code performed. And another reason for me to say what I'm saying, which is a fairly bold statement, because most people will assume that that sentence simply means if you're going to try to do something that doesn't have a CPT code exist anymore, they could be very well right about that. But here's the other thing you need to understand. Then if it's not talking about this document, why is it in here? And that would be one thing I'd say. But the second thing I'd say is this. CPT codes that are not billed with an appropriate accompanying ICD-10 code listed in this article will be denied. Well, it's interesting because that's not actually happening, but that is what should be happening. So that's what everybody needs to understand is if you're going to bill stuff without having a CPT code that exists in the article with its accompanying ICD-10 code, then they should be denying you. You shouldn't be getting paid for that. And that also means you're going to be using an 87999, that unlisted code. Now, to be clear, what I'm saying is there are 7 groups, right? The 7 groups give you what the CPT codes are. Group 1 is a targeted respiratory panel. That's 3 to 5. Group 2 is a targeted gastro panel. That's also 3 to 5. Then there's the meningioencephalitis, which most people are not doing, the bloodstream infections, which most people are not doing, the UG-AG panel. This is basically, for whatever reason, it comes out to being basically women's health. That's your 2 BVAB panels here. I think these are ones that'd be very easy to get a Z code for and get approved for it. And this thing is worth $262, right? These 2 codes are worth $70 a pop. You know, if you've got a test where you only have 2 tests that you're running, maybe that's a good code to use for that. But the real thing comes in on group 6 with the expanded respiratory pneumonia panels, where you're doing something more than 5 pathogens. And there's a couple of extra limitations. Not only do I need a diagnostic code from code group 1, which is the symptomatic diagnostic code, I need a diagnostic code from code group 6. And just to give you an example, if you go to code group 6, you're going to see that there's CPT code, or excuse me, diagnostic codes that go with that. So taking it back to what we were just reading, okay, see here, you'll need 2 codes that are required, 1 from group 6 and 1 from group 1 to be able to get paid. And then on top of that, you'd have to have a patient, an ordering provider that's at this point, yeah, we're doing RPP, a pulmonologist and or an infectious disease specialist, right? So what I'm pointing out is, if you're not going to use a CPT code that exists in the billing and coding article, for sure you need a Z code. And I can tell you what code they're going to give you when you try to do it. It's going to be an 87999. And look, even if you try to do a CPT code on your Z code application for a gastro panel, and you're testing and you do your Z code for more than 5 targets or more than 25 targets, they're going to give you an 87999. I've already seen it happen a couple of times. So you have to be very specific how you put your Z code in. And if you only talk about the pathogens you want to test, they better match up exactly with whatever code it is, because you want this code, because getting a gap fill code, you don't know how much you're going to get paid, right? All right. So we've done that. Let me get back to my PowerPoint.
Hey, William, a good question.
Yes, sir.
So you're talking about in that area that talking about should be getting denied but aren't. Does that leave that open to a potential recoupment in the future?
Absolutely, it does. And so there had been some questions that had come up in the past. If you're not going to pay me for a UTI now, but you have been paying me in the past, and I've been getting paid, $750, and you even asked me for medical records in the past, and then you didn't deny me or you didn't take my money back, do I need to be worried about it now? And this was asked of the Palmetto GBA, not the MAC itself, but the Palmetto that governs the Moldex program, which deals with coverage, not payment. Palmetto, the MAC, does payment. Palmetto, the molecular diagnostic program, is talking about coverage. And they're two separate things, even though they are owned by the same company. And so from a coverage perspective, their answer to that was, no, we don't expect to see anybody doing a look back prior to the date of service when the LCD came into effect. And so this is a problem that we see, is a lot of people will mistakenly assume that because Medicare has paid them, that this was in fact correct, or that it's some certification that everything was correct. And to a degree it is. What it means is you filled out all the fields on your claim correctly. They know who the member ID is. The CPT codes exist in the coding book, but there's a lot of information, the whole point of a Z code, for example, that they're unaware, they have no ability to evaluate. Like another very specific example, very apropos to this concept is, remember how you could be FDA approved and not need a Z code? Well, there's nowhere to put on the claim form whether you're FDA approved or not. So they don't know. They're going to pay it. And then they're going to come back and ask you for documentation at some point and say, hey, how about showing me that 510K you've got for your FDA approval for the test you're running, and you're not going to have it. And they're going to go, well, you didn't have a Z code either, so I'm going to take all your money back. That's a very real possibility, right? You want to pay attention to it. So good question. Okay, so we kind of reviewed all of this. So that was important to understand before some of this other stuff is going to make sense. There is a very important component is we went through code groups 1 through 7. Those are all bundled codes or very specific codes, and you use that code and have a certain kind of diagnostic code combination. Well, there is one additional code group. It's called code group 8. And in code group 8, and we'll take a look at that. In code group 8, what you see are all the CPT codes we would normally use when we don't have a bundled code. Like, for example, say UTI. These are exactly where those codes come from. Each of them, if you're doing PCR amplified probe technique, it would be worth $35, whatever code one of these are, right? There are different techniques. There's direct probe, which will typically be worth about $30. The amplified probe technique is worth $35, and the quantification is worth $40. They all have different levels of how many times you can bill a certain CPT code for. Quantification might be 3 times. Candida, you might even be able to bill up to 5 times, like this code here. Now, that's under normal circumstances. So what we need to see here is, well, they are totally okay with us adding one additional code from this code group if we were using a code from code groups 1 through 7. So that's your RPPs and your GIPs and your meningioencephalitis and your UGAG panels, right? I could maybe add in one more additional code. Oh, yay, another $35, right? Or if I wasn't doing one of the bundled groups of codes that have diagnostic codes, you could use 2 codes from here. Now, there's a couple of things about this, all right? You can obviously tell what they mean is 2 codes, and they mean 2 units. They don't mean, oh, sure, you could go down here and pick this code that you can bill 5 units of, And then we could go down and pick another code, 87999, which has 13. I could build it up to 13 times based on a medically unlikely edit. And then that way I can make an extra $500. That's not what they meant. That doesn't mean if you build it that way, you might not get paid, but that's not a thing you should be doing, because they're going to come back and ask for the money back later, right? So, and the other thing I'm clearly stating is if a code is not in here, like let's say you decide to use something like a 97150, it does not exist in here. And so they've already told you at the top of this document, if you want to use a CPT code that's not here, and you want to use a CPT code that is not in the billing and coding article, and that doesn't have a diagnostic code relationship, well, then that's a no-go. But look, they themselves writing this policy make it confusing as all get out. They said I could use 2 of these, and guess what? I've got no diagnostic code group linking to this code group. And I think they're going to make a mistake and pay that stuff. But I'm telling you, eventually they're going to come back, whether it takes 6 months or 2 years, they're going to come back, they're going to look at it, and they're going to ask you why you did what you did.
William, let me interrupt real quick. We got a couple of questions.
Absolutely.
So we've got a question. So is Z code required for a panel that has, the way I read this, less than or equal to organisms? That's question 1.
Yeah, they're asking the same that question I was just like compounding on about here.
Okay.
So you need a Z code if your test is not FDA approved and cleared, period.
Okay.
Yeah. And
All right.
wait, I just want to show them, they think it means because it's less than 5 pathogens, they don't need it, but they do need it because this thing about less than 5 pathogens is talking about this bullet point here and is directing you to go down here to look at limited coverage for 5 pathogens. This bullet point here is not subject to that bullet point. All of these bullet points are subject to this concept of general criteria. They're all separate little bullet points. You see it's mentioned here again as well, right?
Okay.
They're telling you there's additional requirements that you have to meet if you want to do anything above 5 pathogens. I'm sorry, please continue.
All right. Next question is, what is the minimum number of validation samples required for a successful TA? If so, is it total samples or is it broken down by specimen type?
Okay, I'm not qualified to answer that question, but I believe that I've heard, so I'm now making a comment from a medical clinical professional's perspective that I have overheard. So what I am providing you is overheard information. My understanding that it's the same stuff I picked up in school about standard statistical sizes. So it's like 30 samples or something like that. And they usually talk about splitting it out, but I've heard 30. That's
okay. All right. We got one more and we'll let you get on. For a FDA cleared panel, is a specialist needed to approve?
And an FDA approved panel. Oh, okay. That will be relative to the explicit specific guidance for each panel. So if you were doing an FDA approved and cleared test for less than 3 to 5 pathogens for either RPP or what do you call it? GIP. Well, then the rules for that are you only need 1 diagnostic code from group 1 or 2. So a targeted respiratory pathogen panel, 3 to 5 targets from group 1 needs 1 diagnostic code from group 1. And that set of diagnostic codes are simply symptomatic. The same can be said then in accordance with that as a targeted gastro panel. You just need 1 symptomatic diagnostic code from their group of diagnostic codes and you'll be fine. But once you get to groups 6 and 7, which are down here, where you've got where you're talking about doing 6 to up to 25 targets, this is where these additional requirements come in about the infectious disease or pulmonologist. So the FDA thing is really just related to whether you're Z code or not. So if you were running the BioFire and you were running the 12 to 25 targets, you would need to have 2 diagnostic codes, 1 from group 6 and 1 from group 7, and you would need an infectious disease specialist or a pulmonologist to order it.
Great. Well, thanks for clarifying those. Hope that answered your questions, everyone. Go ahead, William.
Great. Let me see. What am I doing? This one. Where'd it go? Okay, so that was that one. All right. Do you need a Z code? We went over that, FDA approved versus not. Oh, and I can't stress enough, For sure, if you are in a Moldex MAC, your Medicare Advantage plans will need to be billed with a Z code as well now. And that's across all the codes. Although, I wanted to show you something very interesting about this that I just picked up today. This is one of the reasons I didn't want to get into the PGX today. It was this. So they're talking about the remaining waves. And so there have been these 3 different waves, and then there's a list of CPT codes. So I opened that up, and interestingly, first wave, second wave, third wave, guess what's not there? There's no 8,700 codes. So at least it's saying on this documentation that at least up through the 6th wave, which will be before September 1st, they're not talking about infectious disease, right? At least in what they've given us. I think you should be getting ready to do it. And if you already have a Z code and your technical assessment approved, well, then, you know, why wouldn't you start putting it in? It can't hurt you to put it in. But what I thought was very interesting, and what you'll see, what you'll may or may not have noticed, right, is all of these codes kind of, well, these ones start with 81, but all of our codes that we're looking at for our infectious disease are kind of starting with 87, right? Except for the PLA codes. And like, even when I go down to code group 8, they're all 87s, right? And so it's kind of interesting to me that that's not even listed as the thing that United Healthcare and everybody's stating. So I don't know that we necessarily have to worry about it just yet for infectious disease, but it'll be like wave 8 or 9, right? And then the thing to worry about will be, well, is that going to happen when I'm in a non-Moldex state and I have a patient that has United Healthcare Advantage plan? Do I then need to be worried about that I have to have a Z code and I don't even have Z codes? It's coming. That's I've heard them talking about it. They said basically, here's how it works. You will be notified. So be on the lookout from any communication coming in from a Medicare Advantage plan, because they might be telling you that they're going to start asking you for Z codes. And if you don't have one, then they're going to use that to not pay you. All right. And we talked about 87999 and gap bills. We talked about what happens if I use a CPT code that does not exist in the billing and coding article. Well, then you're supposed to use 87999. If you're going to do that, you need a technical assessment and a Z code and a gap fill. What happens if I use a CPT code that exists in the billing and coding article but is not associated with the DX code? They are supposed to deny you for that code. And so you've got a list of diagnostic codes that you need to have with those CPT codes. And they range in number up to almost 200 different diagnostic codes. And in particular, the bigger panels are going to be related to immunocompromised type patients, right? So that's transplants, HIV, genetic and problems with your immune system. Okay, and then a very general summary before I start diving into the individual panels. Non-Moldex MACs, so that's Novitas and First Coast. They have their own LCDs about respiratory pathogen panels and gastro panels, and we're going to even look at those really briefly here in a minute. But one thing I need to tell you about is, whoop, 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 warning, Will Rogers, there is a big coming change for you. And it's going to cut your money down a little bit, because they're not going to pay you for the top tier codes without this immunocompromised diagnostic codes. And you can bet the non-Moldex MACs, whatever they can do to watch what the Moldex MACs are doing, but not use a Z code, they're going to do. So you can expect limitations on how many what the size of a panel it is you can pay for. You can expect limitations coming down the pike at you in terms of diagnostic code requirements and also ordering provider requirements. These things you'll see as I get into them individually. Now, another thing I wanted to point out, Novitas First Coast are actually owned by the same parent company, which also happens to own Blue Cross Blue Shield of Florida as well. So they should be lockstep in terms of what their policies say. And for the most part, for the past 2 years, that's what I have seen. But they are still using 2 separate processing systems. So there are variations in the number of units that one will pay versus another. For example, Novitas will pay for up to 13 units. First Coast will pay for 2 units of anything. And then they're going to ask you for medical records, which will be difficult to deal with. And then NGS is like the wild card, right? They kind of do stuff half in between what Novitas and First Coast does and what a Moldex MAX does. And so we'll talk about those in a minute.
As you transition, William, we have another question.
Sure.
Does Medicare Advantage need a TA or require a TA?
Yes, that's what I was just discussing.
Okay.
So the Medicare Advantage plans, let me just flip it back over to that real quick. So the Medicare Advantage plans are telling you that you're going to need Z codes. And they're telling you what CPT codes you need to have Z codes for by doing it in waves. And when you click on the view list of all CPT codes by wave, I don't see any wave yet utilizing an 8.7 code. But they've only told us about the waves that go out until November. And honestly, I don't know what a United Healthcare is going to think about this, if they are just going to do every molecular code or not. But this is what Palmetto is saying, who governs the MolDX program that United is using. And at the moment, in terms of what is documented for an infectious disease test, no. But for other tests like 8.1, let me see if I can find one that is going to be another hit on you guys. 8.1. Yeah, 8.1. These 8.1.2s, these are biomarker type CPT codes. If you're doing any biomarkers, yeah. And I don't see 8.1.2.2. I don't see any PGXs in here at a cursory glance. 8.1.2. Yeah. So a lot of these are just going to be your biomarkers. Anything you see here with these U codes in them, those are all PLA codes. So I think we're safe right now for infectious disease, but I hope it's not just some undersight or oversight, I guess, whichever way you do it, of them not indicating true and accurate information. But they are indicating that this is a change, and I do not have documented proof at the moment that this has been required for syndromic panels. I do, in fact, have that problem for PGX out of a CGS MAC for not even United Healthcare Advantage plan, but I think it was an Aetna Advantage plan that required a Z code. So what I'm saying is, just because they don't tell you all the codes, they'll always have something in here that says this is not a complete list. So yes, get ready for it. It's going to happen. Now, the next question should be, though, does it matter if I'm in a Moldex MAC? And remember, when I'm saying that Moldex MAC, I'm talking about these states, right? So you have to know, or if you're in Texas, you're not in a Moldex MAC. Okay, so what happens if you get a United Advantage plan in Texas and they want a Z code? Can they make you do that? I think they could. And I mean, I don't think you're going to win that fight. So nobody has said that has happened yet. The only places I have seen any Advantage plan asking for a Z code, and only then it was for PGX, not for an infectious disease. It was up here in CGS in Ohio. But it is potentially coming to us for syndromic panels for all the MolDX MACs. And then, yeah, I do think if these guys can figure out how to legally use that when you're not in a MolDX MAC to not pay you, they're going to do that too, right? So it's coming. It is coming. I don't believe it has happened yet in a non-MolDX MAC.
Real quick, kind of back to the CPT. I have a question here. I'm going to interpret it here, but I think they're asking, are there any CPTs for antibiotic resistance panel apart from 87,500 and 87,641?
Not that I'm aware of. Those two are the only individual codes. There are codes that are at times utilized for that, but are not specifically susceptibility, and therefore very likely easily challenged from a medical necessity standpoint. Also, notwithstanding the fact that if you read pretty much any policy in an outpatient setting, whether I'm talking about a non-MolDX MAC or a MolDX MAC, they don't think an outpatient needs to be tested for microbial resistance, because they will point at studies where their outcome for an outpatient, non-immunocompromised patient needs that kind of testing. Okay. But I have seen Z codes approved for panels that include ABX, but they've gotten the code 87999, which means an unlisted code.
Well, thank you all for the questions. We just for counting of time, we've got 10 minutes left in the presentation. So don't hesitate to add some additional questions that you have them. So thank you, William. Please continue.
Yes, sir. I'll run through the rest of these fairly quickly. In a MolDX MAC, we've already been through what a respiratory pathogen does. in Novitas and First Coast, you're only going to get paid for the 3 to 5 viral targets, and they're all worth $142. This one is I think it's the antigen test, and it's not worth that much. But a new thing for everybody to be aware of is 87913, which is in fact a genomic sequencing of COVID and is worth $215 that Novitas and First Coast are have on their fee schedule now. And I have a more detailed explanation of that code down here. Infectious agent genotype analysis by nucleic acid, and it is meant for SARS, and it's 257. Let's see here. I'll just kind of go through the highlights. Commercials, most of the time, they're going to limit you to 87631, very much the same way that Novitas is. They're not going to pay for the 32 or the 33, that should have been, which are the 6 to 11 or 12 to 25 targets, right? So commercials are very much like that, but they will pay for these 3 codes that, Novitas and First Coast will, which are all worth $142. I think one of the things that people need to understand is that that's respiratory pathogen panel, and it's not COVID only testing, and therefore it's not covered by the CARES Act, and therefore you're going to have patient responsibility. And if you're on a network, that means a big goose egg most of the time. So if you've got a toss up between which one you want to do COVID only, so you get your full $100 until the pandemic is over. Now, as far as GIP panels go, there's a consistent philosophy of what's happening here. As we went over with the Moldex, right? I can build a low tier, 3 to 5 targets for, I think it's, for some reason, it's not $142. It's slightly different. It's like $122 or something, I think. But the 87506 and the 87507 kind of mirror what an RPP panel is. So the top end that they pay is $416. And you just need 1 diagnostic code for the lower paying one. You need the 2 diagnostic codes for the bigger one and the infectious disease specialist ordering it. Non-Moldex Max, so Novitas and First Coast, I can get paid for all 3 of those, and I only need, R19, which is acute diarrhea. There is a proposed LCD that will limit you from that payment, that they will change that as soon as you want 87506 and 507, you can still get that for your R17, but you also need your you'll need the immunocompromised or immunosuppressed diagnostic code. NGS is already that way. With just the 1 tier code, you could use the diarrhea code, or I think that's, oh man, there's a word for that. I can't remember right now. Uh-oh, what's going on? Are you guys still with me? Did I lose you?
No, you're back. Thank you.
Okay. So then what you can do is you get paid for the low tier. The other 2 tiers, you need the immunosuppressed diagnostic code. Commercials are basically the same, right? Cigna will only pay for 87505. They won't even consider 506 or 507, the bigger panel, right? Blue Cross, United, Aetna, Humana, they'll consider 505 and 506 when you are basically have R19. They'll consider 87507 the bigger panel when you have everything from the preceding panels plus an immunocompromised. So you're seeing how infectious disease is evolving down that path. Now, there's something really important we need to talk about. It's UTI, nail wound, and ophthalmology, or anything else you want to make up. If it doesn't exist in the billing and coding article, and it doesn't already have a bundled code, that means you get 2 codes, and that would mean $70. That's not going to work for anybody for their UTI. So you're going to get an 87999. You're going to have to fight about what you're going to get paid for it. You have to overcome your TA not being passed because you don't have the clinical utility because of the false positive narrative, and there not being a standard of care for the physician to deal with the false positive potentiality. And that's because it's so sensitive. That's the problem why you're not passing your TA. And if you have that problem with a UTI, which was at least mentioned in the LCD, but never in the billing and coding article, wound and nail and STI and ophthalmology were not mentioned. Actually, that's a misnomer. Nail was mentioned in 1 sentence. The CAC the committee that put together the LCD said, we don't think nail is medically necessary when done on a PCR platform. They didn't even address wound or ophthalmology. STI is addressed, and the concept there is, yeah, we expect you to do like 2 tests at a time.
William,
Yes, sir.
regarding on that UTI that you're talking about, we have another question on that. When to use CPT 87150? What are the major payable ICD for UTI panel test PCR amplified technique?
What's the code?
Yeah.
No, did they? I thought I heard 87.
Oh, no, the code was 87150.
Okay, so yeah, this is an interesting one. What this is you were supposed to have done a culture previously. 87150. I was just looking at it the other day. Okay, culture typing identification by nucleic acid probe per technique, per culture, per isolate, for each organism probed. Following a separate procedure to culture, isolate, and specifically identify an organism such as a bacterium to the genus and species level, the lab analyst uses amplified nucleic acid probes that will identify specific DNA. So first of all, you have to be doing microbiology. You would have had to probably done a colony count. Then you would have done you would have cultured it to identify at the genus level, the bacterium that you're looking at. And then what you're saying is you're going to run PCR to determine susceptibility. That code does not explicitly say susceptibility, so there's some weakness in that code there. There's also the potential of somebody asking you why you're running 2 methodologies to test for one indication, because you're going to be doing cultures and you're going to be doing PCR for the same purpose of your test, whether it be for UTI or nail or wound or STI or whatever it is you're doing it for. I also wanted to point out that code does not exist in the billing and coding article. The billing and coding article is clearly telling you, if you use a CPT code that does not have a diagnostic code relationship, they want you to use 87999. Do I think it will pass their edit? Yes. Do I think you're going to have trouble with it later? Yes. But it is something that if you were maybe going to do a culture and not do a PCR for anything else but for that, maybe you could do that. But again, because it's not in that LCD, and you are doing a nucleic acid amplification test, because it's not a culture test, it is nucleic acid amplification, it does fall under the jurisdiction, and thus I think you will see that you'll have problems with it. I mean, when you get the Z code, they'll tell you what the right CPT code is, and it'll be an 87999 for sure. So what are you going to do between now and then? I don't even think you should be billing anything until you've got passed the technical assessment, because they're clearly telling you you are not demonstrating compliance with the policy. And now that the policy is enacted, I think we're going to have a hard time when Medicare wakes up. It's a lumbering giant. They put a policy out. They haven't changed their database flags yet. They're not checking this stuff yet. And then people want to know if there's going to be a grace period or something. I mean, like, the grace period was the comment period, and it's over, right? So at some point, they're going to come back and they're going to ask you a bunch of questions, right?
All right, we have one last question here, then we're at the top of the hour. Any update on PAMA, P-A-M-A? Is it coming on January 2023?
I don't have a current update on that. My apologies. I'm not prepared to speak intelligently on that topic.
That's okay. We appreciate your honesty. Again, we're at 12:58. We're reaching the top of the hour. Any other questions? And William, I'm sorry, you got a lot more information, I know, but any other questions? Go ahead, William.
One more. So monkeypox does have a fee schedule now. It's $51.35 for Novitas. It's $35.09 for Noridian. LabCorp is billing $99 for it. And the diagnostic codes are related to fever, headache, backache, neck ache, fever, and lesions. And you do have the ability to have, if you're working with a billing company, they'll put together what those diagnostic codes are for you to put on somebody's plate for that. The last thing about COVID testing I would say is you don't need a Z code for COVID only testing. If you're using a PCR CLIA waived little tiny machine, that's $50. It's not that your big high throughput machines. You don't get your $100 for that. pay attention to how you're coding your antigens, right? If you're looking at a line, it's an 87811, not the other code that everybody bills still. Do not be billing G codes to Medicare. The over-the-counter code is K1034. It's $12. Medicare will pay for it, and Humana will. The other commercial payers don't have any stated policies on it. I would try that code if you did, but do know that they don't want to pay for it. They do not want their patients getting it, and they want them to go to Medicare for it. And the last, I think, interesting update is this genotype analysis. It was a big thing back when COVID was a thing, was I want to test for genetic variation of the, I want to know the variant for COVID. That's the code for that. That's worth $257. I'm really suspicious, though, that that is going to be medically necessary for your average person, because there aren't too many changes in treatment. And so therefore your clinical utility will be thrown out, but it does exist. So find out what makes it medically necessary and then do what you need.
All right. One last question popped in. Is UTI panel payable through ICD?
There are no ICDs. There is no UTI panel. Did you say UT or UTI?
UTI.
Yeah. Okay. Yeah. There is no CPT code group for UTI, unless you're talking about code group 8, because that's not a code group for UTI, right? There's no code group for just UTI. There is none. There is no approval for it. You need a technical assessment. You need a Z code. You do not have any diagnostic codes that are listed to support medical necessity in the billing and coding article. This is why you have to have your technical assessment, and then you need to get approved. There's one more thing I want to show everybody real quick. This is really kind of important for everybody to see. I want to show you what a Z code looks like when you get one, and what it looks like when you get an 87999 given to you. Oh, come on, man. There we go. All right, real quick. When you apply to get your Z code, it'll be listed here, your test ID and who you are will be here. And you'll put down the CPT codes you want to get paid for that, right? This happens to be, I think, this would be a UTI because it can be in there. Now, they have no Moldex recommended code. These people, if they were to bill, they are likely to be paid at this CPTs, but that would be incorrect. They do not have a recommended CPT code yet. This is what it looks like if you've done it poorly. You get an 87999. Well, I don't know. I can't say poorly. This is obviously some kind of a very small respiratory pathogen panel. And what the problem here is you didn't just do an 87632. You tried to do all this other stuff. And then they said, you know what? 87999 for you then, buddy. What you should have done is an 87632, gotten your $142, or excuse me, 262, I think, and been done with it, called it a day, right? But anything that you do that's outside of what actually fits into the panel that you see in the billing and coding article, this is what they're going to give you, an 87999. So anyways, that's all I'm at. It's really important. And if you want to get the Z code right, and pass a technical assessment for something that exists in the billing and coding article, that should be easy. What you're going to have horrible time getting done will be a UTI, a wound, a nail, even an STI, right? Because you don't even really have a code group for STI. Oh, right. Wait. One last thing. Oh, this one is, I swear to God, it'll be done in like 10 seconds. I just want people to see what PCR is from a commercial perspective. Come on. Work. Okay. This is Aetna's policy on PCR. They consider the following PCR experimental investigational. There's a list of, I think, 104 things in here. Every one of these kind of bacteria, look, chlamydia, they think that's not even necessary. That's an STI. A lot of commercial payers will pay for an STI, but they're not going to do E. coli. Like, look, see, they're not going to do Enterococcus. They're not going to do E. coli. And so then you're thinking, oh, that's not Legionella, all this stuff. These are what you see in all of our panels, right? Very interesting too. See, Rhinovirus, which is actually that's a code that exists that they're supposed to pay for. Staph and strep not paying for. Now look at this. They literally tell you, I don't want to pay for urinary tract infections. If you bill Aetna, a urinary, a UTI, and you've included STIs in it and the microbial resistance, let's say, you might make it $200 out of it. But that's because they're going to pay you because they don't know they're paying you for a UTI. And it's inappropriate. If they actually came back and realized it was a UTI by simply running a diagnostic code check and going, that's a diagnostic code for a UTI, they'll take the money back. So just because you get paid from payers doesn't make it right, is all I'm trying to say. You need to know what your policies are, and you need to work with a billing company that's going to do that work for you, like we would. And also notice down here, wound infection, not paid for. And you will see very similar policies like this across all commercials. And everybody's going to tell you, oh, I'm doing it and I'm getting paid. Well, you probably shouldn't be, number one. And number two, the payer that is paying them doesn't know what they're paying for because we're using a bunch of codes that the payer is not familiar with, right? Or hasn't actually made a good policy to block people from getting paid. That's what's happening. Sorry. I am done.
That's good. No, William, you got a lot of wealth of information. We greatly appreciate it. We will address, so we see I see another question too. We'll get those addressed after the webinar, but we want to say thank you for everybody taking your time out of your day to join us, and certainly take time to fill out the questionnaire and the survey that will be attached after this webinar. Also be looking for it to be posted in the next 2 or 3 weeks for you to share with your colleagues. And certainly it goes without saying, if you have any additional questions you want to ask directly to William, certainly feel free to reach out. If you have any questions about our RCM services, what we do from a coding and billing service standpoint to support people like yourselves and your entities, we'd love to talk to you about those opportunities. But again, thank you for joining, William. Great information. And we look forward to seeing everybody on the next one. Have a good day.